She serves as the Director of Experimental Therapeutics in the Division of Pediatric Hematology Oncology and has led a multidisciplinary young women's hematology clinic at Nationwide Hospital. Her clinical and research interests include pediatric thrombosis and thromboprophylaxis, the evaluation and diagnosis of mild bleeding disorders, and the intersection between hematology and women's health. As a fun fact, she was here in Dallas in September, and when she was at the AT&T Stadium, they asked if anybody was familiar with the Dallas Cowboys cheerleader show, and she's the only one who raised her hand. And as another fun fact, she's just a delightful friend and colleague. So anybody who ever gets to work with her is very lucky. Okay.
So it's a pleasure to be here this afternoon. Congratulations on being in the home stretch of your board review course. Per the agenda, this talk is supposed to be an hour and 20 minutes, but I know we're running behind, so I'm going to try to pick some slides as we go through that you can read on your own. How we're going to organize this is we'll talk first about the signs and symptoms of some different types of thromboses. Then we will talk about inherited and acquired risk factors for thrombosis. We'll then move into management, and I'm going to focus mainly on the different types of anticoagulation and the mechanisms of action, because that's what you're most likely to be asked on the boards. And we won't get into a lot of nuances regarding when to prophylax, when to treat, how long to treat, etc., because those are more controversial and less likely to be asked in the setting of a board exam. And then finally, we'll talk about thrombolysis a little bit, and then wrap up with post-thrombotic syndrome. I just wanted to say as an aside from watching Guy's presentation, I just recertified last year, so it was a little bit of PTSD, but I can let you know that I definitely needed to know the table on type 2 von Willebrand disease that he suggested you memorize. I think that came up on 2 different questions for me. I needed to know the clinical presentation of a person with an iliopsoas bleed. I needed to know that a patient with hemophilia who all of a sudden was starting to bleed again, that I needed to look for an inhibitor. And what's the other one I wrote down? I needed to know that a patient with severe hemophilia was likely to have an intron inversion, whereas mild was a missense mutation. So those were all questions on my exam last year. So first, the signs and symptoms of deep vein thrombosis. So this patient is presenting with a typical presentation. This young man probably had calf pain for several days and then woke up one morning with all of a sudden increased pain, now with swelling and some reddish discoloration of that calf. And if you're examining him, you'll note that the right calf feels warmer than the left. Patients with catheter-related thrombosis, which we see a lot in pediatrics, can have a very similar presentation in terms of extremity swelling, pain, and discoloration. Of course, you can also have the clue of line malfunction as a presentation of catheter-related DVT. But remember that patients with indwelling catheters can present more as this chronic, quote, asymptomatic picture. In this case, the clues are going to be increasing problems with drawing back from the line or infusing the line, a development of increase in superficial vessels over the chest wall. And remember that there's an association between infection and thrombosis. So if a patient is struggling with recurrent line infections, is there a thrombus in there that's the nidus for these infections? When talking about pulmonary embolism, in adult medicine, you're taught about this classic triad of chest pain, shortness of breath, and hypoxia. And I do find that many adolescents present with this classic triad. Definitely the chest pain, shortness of breath, plus minus hypoxia. But as you get younger, only about 20% of children will have this classic triad at presentation. So whenever you have a hospitalized patient, or particularly a critically ill patient who all of a sudden has a decompensation in cardiorespiratory status, you need to keep pulmonary embolism on your differential, because the younger the child, the more nonspecific the presentation will be. I've also seen fever as a cause, as a sign, predominantly in hospitalized patients. Cough, rare, I've never seen hemoptysis. Rapid or irregular heartbeat, yes. And certainly in a patient who's coming in with chest pain and lower extremity swelling, or a recently diagnosed DVT, you're going to definitely think about pulmonary embolism. Next, let's talk about cerebral sinovenous thrombosis. And just to be very general, I think of this as being lumped into 3 categories. So you have your neonatal patients with CSVT who are likely to present with seizures. You have your adolescent patients, typically an overweight female who's presenting with headache and papilledema, more that pseudotumor cerebri presentation. And then in the middle, in those preschool, school-age, young adolescent patients, commonly they are patients who have a CSVT found incidentally during imaging for a really bad ENT infection, whether that's mastoiditis or lymphadenitis. So in general, those are the 3 kind of categories of patients I see with CSVT. And finally, we'll talk about portal and renal vein thrombosis. Unlike DVT, PE, and CSVT, these are more likely to have insidious onsets or maybe picked up on incidentally on imaging. So while portal vein thrombosis can present as an acute abdomen, it's more commonly asymptomatic until the patient starts to have problems with chronic portal hypertension, such as splenomegaly or esophageal varices. And you'll see this in patients who have had a liver transplant, in patients with liver infections, or in patients who are receiving chemotherapy, or also patients after splenectomy can have portal vein thrombosis. Renal vein thrombosis we predominantly see during NICU consults, although you can see it in patients with nephrotic syndrome or after a kidney transplant. And again, this is more commonly going to be an insidious onset, but you can have symptoms of hematuria, anuria, proteinuria, and thrombocytopenia. If the renal vein thrombosis extends into the IVC, then you will start to see lower extremity swelling. So you need to keep that in your differential in the NICU when you see a patient who all of a sudden has bilateral lower extremity swelling. Then we'll talk about laboratory measures, and I pick my words carefully here because they're laboratory measures you're doing at the time of diagnosis and not for diagnosis. There's not a lab test that's going to tell you whether a patient has a thrombosis or not. And that's because the D-dimer is quite nonspecific in pediatrics. It's likely to be elevated due to the underlying chronic disease or infection that the patient has, or in a patient with a more insidious onset, it might be negative at the time of presentation. For a patient that you've just diagnosed with a thrombosis, you want to check a CBC, you want to make sure their platelet count's not low. You want to know what their baseline PT, PTT, and fibrinogen is, because these are likely to change once you start anticoagulation. For patients presenting with severe iliofemoral thrombosis, I'll sometimes check a D-dimer and a factor VIII because I'm also looking at these as a prognostic sign for poorer patient outcomes. If you're going to start low molecular weight heparin, you need to make sure that they have a normal creatinine and renal function. Before you start warfarin, that's a teratogenic medication, you need to make sure they're not pregnant. And a thrombophilia evaluation I put here because almost always you don't need to do this at the time of diagnosis. It's not going to change your initial management, and as we'll discuss in a little bit, you can get false results in that acute phase. Last, I wanted to talk about when a child presents with an established DVT of an unknown cause. And this is pretty rare in pediatrics. This is that healthy adolescent that walks in off the street into the emergency room with a severe upper extremity, lower extremity, or IVC thrombosis. And in these cases, you're automatically going to think of inherited thrombophilias or anatomic variants. And so these are the cases where I will do protein C, S antithrombin levels when I meet the patient, because I want to get an initial idea of whether that's something we could be dealing with here. These are also the patients that I'm going to look for antiphospholipid antibody syndrome, because they can present like this. And then we'll look for those anatomic variants depending on where the thrombosis is. And we'll spend a slide specifically on May-Thurner and thoracic outlet syndrome. So for May-Thurner, this is a patient presenting with a left-sided, usually severe iliofemoral thrombosis. Much more common in females, although I can't find a reason in the literature to explain that. And they typically present as an adolescent or in their 20s. So as pediatric hematologists, we definitely see these patients. You diagnose the May-Thurner syndrome with MRI typically, and what you'll see is a narrowed left iliac vein, and that's due to compression from the right iliac artery. So if you look at this image, the arrow is pointing to a dark space where we should be seeing a left iliac vein, but we're not seeing a left iliac vein. And then that wishbone in the front, that's easy to see, that's the right iliac artery and vein, right and left iliac arteries. So you're seeing that that right iliac artery has completely shut down the left iliac vein. This is a patient with upper extremity thrombosis who presents with subclavian axillary vein thrombosis. We call this Paget-Schroeder syndrome, or also thoracic outlet syndrome, or exertional thrombosis. I personally have seen this only in adolescents, and every patient I have taken care of with this has been an athlete. They're either a baseball pitcher, softball pitcher, swimmer, volleyball player, something where they are raising their hand above their head a lot during their specific activity. So what's going on here is there's compression of that subclavian vein due either to a difference in the muscles or a difference in the ribs around that area, or sometimes the vein just becomes narrowed due to this chronic exertion activity that the patient is doing. So for these patients, a first rib resection can be quite helpful. And these are also the patients at our own institution that we're more likely to consider thrombolysis in at the start. And this figure is showing in panel A, you can see that you are being able to see the subclavian vein, but then when you do the imaging and the patient has their arm raised above their head, now that area has become quite narrow. So when you're getting MRIs for these patients, it's a special kind of MRI where they will have the patient take different positions. So now we're going to move into inherited thrombophilias. The list on your right is a list of tests you can do to perform an inherited thrombophilia evaluation. The tests in red are the ones that I tend to do in my practice for whatever that's worth. I think a more important question is, when do you send these tests? There's a great up-to-date article by Leslie Raffini on inherited thrombophilias that I recommend you take a look at. And I follow her recommendations pretty closely. So I don't do thrombophilia workups in patients with line-related thromboses. I do thrombophilia workup in patients with non-CVL-related thromboses, unless there's a ton of clinical risk factors all at the same time. Like, I just had a patient who had breast reduction surgery. She was immobile at home, she's overweight, and someone started her on OCPs the next week. So I did not perform an inherited, she didn't have a family history of thrombosis. So in that patient, I felt pretty comfortable that it was just a storm of clinical risk factors. I do check for inherited thrombophilias in patients with recurrent thrombosis. I do a lot of young women's hematology, so another time when I'm sending these tests is when a patient is wanting to initiate hormonal contraception, but has a strong family history of thrombosis, and we're trying to determine whether estrogen is a safe choice for that patient. Let's talk about some of the thrombophilias in more detail. First, we'll start with factor V Leiden, which is the most common inherited thrombophilia. It's more common in Caucasians in about 5% of the general population. What happens with factor V Leiden is this mutated factor V becomes relatively insensitive to the actions of protein C. Remember that our body has 3 natural blood thinners, 3 natural anticoagulants, protein C, protein S, and antithrombin. So by this difference in the factor V, the protein C is not able to work as well to be a natural anticoagulant, and it shifts that whole coagulation cascade more to the hypercoagulable state. There's 2 ways to test for factor V Leiden. You can do genetic testing to look for the difference. You can also do a functional assay that's looking for protein C resistance. The functional assay is typically less expensive, but less readily available. For example, at my own institution, we don't have the functional assay. And thinking about the clinical phenotype of factor V Leiden, I think about the number 4. It increases your risk of VTE about 4 times greater than the general population. The number 4 will come up a few more times in this presentation. So think venous thrombosis. The data on arterial thrombosis and obstetrics are much more mixed. It may play a role in some women who have recurrent late pregnancy loss, probably due to placental thromboses. What I emphasize the most when I'm doing counseling for factor V Leiden in clinic is that the majority of patients are asymptomatic. There have been great large studies following these patients over time. 95% of them never have a blood clot. And I just say that our role as the hematologist is to make sure that they remain in that 95%. So for patients with factor V Leiden who do develop venous thrombosis, they have a low risk of recurrence. It shouldn't alter your decision-making regarding the intensity or duration of treatment. So that's why I told you it's not necessary to check for this when a patient presents with thrombosis. And more recent data is actually suggesting that even in patients with homozygous factor V Leiden, their risk of recurrence isn't any higher than the general thrombosis population either. Next, we're going to talk about prothrombin gene mutation, which has many similarities to factor V Leiden. So I definitely group them in the same category in my mind as common but mild inherited thrombophilias. Again, it's more common in Caucasians, in about 2% of Caucasians as compared to 5% for factor V Leiden. And I remember factor V, 5%. What happens here is it's an amino acid substitution in the prothrombin gene. And so patients that have this genetic mutation make more prothrombin. Their levels of prothrombin are about 30% higher. So if you look at the figure on the right, you can remember from the coagulation cascade that if you have more prothrombin, follow the arrow, you're going to have more thrombin generation. That patient is going to be hypercoagulable. The clinical phenotype of prothrombin, I think for board purposes, is identical to factor V Leiden. Remember that number 4 again, their risk of venous thrombosis is increased by 4 times, and their role in arterial or obstetrical thrombosis is minimal, if any. And there's a low risk of recurrence, even in patients with VTE who have prothrombin gene mutation. Because factor V Leiden and prothrombin gene mutation are fairly common, we definitely see patients who are double heterozygotes, and that is different. It's not an additive clinical risk, it's an exponential clinical risk. And those patients will have about 20 times increased risk of thrombosis and may have increased risk of recurrence. So we're moving from mild and common to rare and severe, and we're going to focus on antithrombin, protein C, and protein S. I'm going to spend a fair amount of time on this table because there's a lot of important things in here. So first, you can see how these are much more rare. These are not frequencies in the general population. These are frequencies in patients who developed a venous thrombosis, so very rare entities. Again, just like factor V Leiden and prothrombin gene mutation, think venous thrombosis. That's by far the most common type of thromboses that these patients get. Antithrombin has a particular association with pregnancy-related VTE. Unlike factor V and prothrombin, where we talked about how 95% of patients will never develop a clot, that's not the case here. I'm sorry, there's a missing box there under protein C. That should be 70% in that box. So in these patients, 40 to 70% of them will develop a thrombosis. They usually start developing their thromboses in their early 20s. So we as pediatricians are going to see them. If they have a family history of thrombosis, they typically start presenting at younger ages. The risk of VTE recurrence is very high in these patients. If they're adults and they're getting their first thrombosis, they put them on anticoagulation and they're there for life. I think in pediatrics, we value more the benefits of avoiding bleeding, being able to participate in sports, not committing patients to lifelong anticoagulation. So even in patients with these severe deficiencies, I will usually treat them for a longer duration for their first clot, and then I will just watch them closely off anticoagulation, because sometimes it can be 10, 15, even 20 years before they develop their next thrombosis. And that's a big deal in terms of quality of life and anticoagulation. The other important point I wanted to make is that there's overlap between heterozygotes and normal levels. So let's just look at protein S, for example. Normal levels are between 60 and 120%. Patients with protein S deficiency will have levels less than 35%. If you're seeing a patient with a level of 40 to 50%, they usually just had a thrombosis and are having some consumption because of the acute thrombosis. Their body's trying to use its own natural blood thinners, or they're a patient who's pregnant, or they're a patient who's on birth control pills, or they're a patient with sickle cell disease. They have some other reason for having a mild deficiency in protein S. So that's why when I'm seeing that healthy adolescent with the new big bad thrombosis in the ER, I do check things like protein S, because I find that if they really have protein S deficiency, that level is going to come back at 10 to 15%. And even if it increases a little bit later, I have a heads up that this is probably inherited protein S deficiency. We can start talking about that with the family and the implications of that. I know I'm going to treat that patient longer. This table is all talking about heterozygous protein C, S, and antithrombin. Homozygous is a very different situation. Antithrombin homozygous deficiency is probably incompatible with life. We do rarely, very rarely, see patients with homozygous protein C or S deficiency, like a large clinical setting, like where I am, for example. We have like 1 or 2 patients at a time that have this. These patients present as neonates with purpura fulminans. The picture here from Dr. Monagle in Australia is a classic way that these patients will present. So what you need to know when you need to see this in the NICU is FFP, because you're automatically thinking there's protein C or S deficiency, they're both in FFP, so let's give FFP. Once you know more about what's going on, there is protein C concentrate available that can be used for these patients, and these patients will definitely need to be on long-term anticoagulation for their whole lives, although there have been case reports of liver transplant to treat these patients. One other thing to remember is that these levels of natural anticoagulants change with age. So if you're getting a consult for a neonate or an infant with a low level because they're checked due to family history, especially if they're done in an outside lab that doesn't have pediatric specific values, these levels are all low in infancy, particularly in premature infants. Antithrombin and protein S increase fairly quickly. They reach adult levels by 6 to 12 months of age. But protein C activity remains lower than adult levels all the way through the teen years and even in your early 20s. So if you're seeing a kid with a family history and their school age, even if their levels are mildly low, I will likely recommend repeat testing when they're in adolescence. And I just, for example, I couldn't believe the family remembered, but they came back 6 years later to see me. I tested her, and she was normal, and she doesn't have protein C deficiency, even though her mom does. And that was important at the time because now we were making decisions about contraception for that patient. The other thing that I think is, a board exam question rather than something you're likely to see in real life is that you'll see a picture like this on a patient that's been started on warfarin. So what you need to remember, and we'll talk about this when we talk about the anticoagulants, is that warfarin inhibits the synthesis of all vitamin K proteins. And that oftentimes we remember 2, 7, 9, and 10, but you can't forget that protein C and S are also vitamin K dependent proteins. So what happens actually when you start someone on warfarin is that the protein C levels decrease faster than anything else. So when you first start a patient on warfarin, you're actually making them more hypercoagulable. That's why we don't start patients on warfarin alone. We always start them with unfractionated or low molecular weight heparin. So patients with protein C and S deficiency are more likely to experience warfarin skin necrosis. Next, let's talk about acquired risk factors for thrombosis. These include more chronic diseases like cancer, cardiac disease, inflammatory bowel disease, obesity. They also include acute conditions such as infection, surgery, trauma. Certainly in pediatrics, the number one acquired risk factor is the placement of a central venous catheter. In a cruel twist of fate, I only had 2 thrombosis questions on my test last year. One of them was an incredibly complicated lupus patient in the ICU, and they listed several different risk factors, and you had to say which one would not increase her risk of thrombosis. I wanted to make 2 points on this slide. This is from a paper that looked at VTE discharges in community and children's hospitals in patients 18 years and under. So in discharges that included a venous thrombosis, the most common chronic conditions for those patients were cardiovascular, malignancy, and neuromuscular disease. For acute issues, it was infection and trauma and surgery. The other point that I want to make with the bottom of the slide is this is looking at the acute versus chronic ratio, and you can see that in those older adolescents, thromboses due to acute risk factors such as trauma, infection, oral contraceptive pills are much more common. And many of these patients were actually being cared for in community hospitals, so we probably aren't aware of them as much. I'm going to briefly touch on arterial thrombosis because the risk factors are a bit different. So when you're talking about arterial ischemic stroke, often these patients have underlying cardiac disease or there's a problem with one of the neck arteries. Patients with cerebral vasculopathy, such as Moya-Moya disease, or patients with sickle cell disease have increased risk of arterial stroke. You can also see this in patients with severe sepsis and dehydration or really, really severe iron deficiency anemia, and I have seen that in clinical practice. Of that list of the thrombophilia tests that I showed, hyperhomocystinemia and elevated lipoprotein A are the only 2 that you really think about when somebody has arterial thrombosis. Other arterial thromboses are typically catheter-related, either umbilical artery thrombosis in the NICU or femoral artery thrombosis after a cardiac cath. Perinatal stroke could be a whole talk on its own, but know that the risk is multifactorial due to fetal variables, maternal variables, and variables at the time of delivery. I wanted to spend just a minute on estrogen-containing contraception, because I think this is confusing for a lot of people. So we're not sure exactly why estrogen triggers thrombosis, but we do know that when you take estrogen, it reduces your protein S activity a bit, and it increases your protein C resistance. Looking at the figure, remember that protein C and protein S are working together to inhibit factor V. So if they're not working, your factor V is a little bit out of control, and you're shifting things towards the hypercoagulable state. That number 4 is coming up again. If you compare users of estrogen-containing contraception to non-users in adolescence, you increase your risk of the absolute risk of thrombosis is still quite low, but you're increasing your relative risk by 4 times. So when you take a birth control pill, it's kind of like giving yourself factor V Leiden. That's how I think about it. In clinical practice, most of the teens we take care of with birth control pill-related thrombosis have something else going on. They're often overweight. There's also a family history that maybe wasn't thought of at the time of prescribing the agent, or they turn out to have an inherited thrombophilia. And I see this confusion a lot, so I just wanted to remind everybody, for people that don't prescribe or manage these agents a lot, that the birth control patch also includes estrogen, and the vaginal ring contains estrogen. I see patients sometimes with known risk factors being prescribed a vaginal ring because people confuse it with IUDs that are progestin only. Last, we'll talk about the antiphospholipid antibody syndrome, and I'll try to make this part a little bit shorter, but antiphospholipid syndrome is when you have a patient with a thrombosis who has evidence of antiphospholipid antibodies, persistent evidence, 12 or more weeks after the thrombosis occurred. It's also looked for in women with recurrent pregnancy loss. The laboratory evaluation, you're going to check for lupus anticoagulant, anticardiolipins, and anti-beta-2 glycoproteins. And in patients with antiphospholipid syndrome, this is not going to be a mystery. All 3 of us are going to come back sky-high positive. The management in adults is definitely lifelong anticoagulation. I think that in pediatrics, it's less clear what we should do in these patients. My younger patients, I'm more likely to think about stopping anticoagulation. I may watch their antibodies. If they're decreasing over time or they resolve over time, I might try to wean them off anticoagulation. For my adolescent patients with underlying lupus, things like that, I keep them on lifelong anticoagulation. I think I'll skip this slide because it's a bit dry and for the sake of time, but I think a lot of people get confused about what are you actually looking for when you check for lupus anticoagulants. So that's just a description of what that testing is. Next, we'll move into anticoagulation. So this slide is showing the different families that we're going to talk about in the next few minutes. So if you look on the right, we're going to start with the heparin family. And these are indirect inhibitors of thrombin and factor Xa. Then we'll talk about the vitamin K antagonists, and I'll drill into you again, 2, 7, 9, 10, C, and S. That's one of those things that, like, when you get to the boards and they have that little dry erase board next to you, you just write it down, along with the von Willebrand type 2 diagnoses. Then we'll talk about the direct inhibitors. The direct thrombin inhibitors aren't on this slide, but we're going to talk about them. And then we'll wrap up with the direct the direct 10A inhibitors. Okay, so unfractionated heparin is a naturally occurring anticoagulant. It consists of molecular chains of varying lengths. It binds reversibly to antithrombin. And after binding, it's going to increase antithrombin's inhibition of thrombin and factor Xa. And it binds non-specifically to a variety of plasma proteins. So when I'm thinking about unfractionated heparin, I kind of think of nebulousness. Like, it consists of chains of varying lengths, it binds back and forth, it binds to thrombin and Xa, it binds to a bunch of other random plasma proteins. The PTT is really hard to follow. Like, anything nebulous, I think of unfractionated heparin. And then when I'm comparing that to low molecular weight heparin, I'm thinking of something that's much tighter and more specific. So for low molecular weight heparin, now we only have short chains of the polysaccharides. They have a preferential effect on 10A and are less able to inhibit thrombin and less able to bind to those other plasma proteins. So when you think about that, it makes more sense about why it's much more easy to manage low molecular weight heparin. It has much more predictable pharmacokinetics, less variability, and a longer half-life than unfractionated heparin. Then I think about fondaparinux, which we don't use as much in clinical practice, but that's the most specific of the group. So it is only acting on 10A, and it's enhancing the activity of antithrombin by 300-fold, much more than unfractionated or low molecular weight heparin. Doesn't bind at all to other plasma proteins. And the other nice thing about fondaparinux is it's once daily dosing as compared to twice daily with low molecular weight. I already alluded to the difficulties with unfractionated heparin and monitoring. So the point of this slide is that whether you're using the PTT or the anti-10A or the ACT, they all have problems and they're all sensitive to different variables. When you're monitoring an unfractionated heparin, because you're dealing with a short half-life, you're going to want to check a level 4 hours after you make any dose change, and then daily after that. Low molecular weight heparin, as you can see from the figure, the peak level of low molecular weight heparin is occurring about 4 to 6 hours after you give that dose. Your goal is 0.5 to 1 units per ml, and it's measured by the anti-10A level. And I think you all know that it's measured by the anti-10A level, so when you get stressed out in the exam, like just remember what the lab is, and then it reminds you what the mechanism is. The half-life is about 4 to 7 hours. The initial dose is typically 1 milligram per kilogram. Remember that infants are going to need higher doses because they have a larger volume of distribution. So you're going to start them on 1.5 milligrams per kilogram. What I see in clinical practice all the time is that you have to watch out for low molecular weight heparin buildup in those adolescents, particularly overweight adolescents. I find that they're therapeutic in the hospital, and then I'm seeing them a few days later in clinic, and they're having nosebleeds or a really bad period, and you see that they're super therapeutic. So oftentimes, I almost never see an obese teenager who actually needs 1 milligram per kilogram in the end. So make sure to do monitoring pretty closely at the beginning until you have them established. Just to remind you of some of the differences between unfractionated heparin and low molecular weight heparin. Unfractionated heparin is a continuous IV infusion, so that makes it a good first choice in our unstable patients. They're going to go to the OR soon. We're worried about them bleeding because you can turn it off quickly and it's completely reversible with protamine. Low molecular weight heparin is a subcutaneous injection, which isn't popular with anybody, but it's much easier to use in a stable patient. It has more predictable pharmacokinetics. And you can still get incomplete reversal with protamine. Just remember that patients require good renal function to be able to tolerate typical doses of low molecular weight heparin. Last, I'm going to talk, before we move on from heparin, I'm going to talk about heparin-induced thrombocytopenia, which is definitely something you see on the boards more than you see in real life. And that was my second thrombosis question last year, was a patient with HIT. So how HIT works is it's a rare but life-threatening complication of exposure to heparin, so it's important to know about. And what happens is that heparin is forming a complex with the patient's platelet factor 4. And the patient then forms autoantibodies against that complex. This results in thrombocytopenia and thrombosis. The thrombocytopenia occurs because the antibody-coated platelets are being removed by the reticuloendothelial system. The thrombosis occurs probably because the platelets are becoming activated. It occurs in 1 to 3% of adult cardiac surgeries. If you read the literature, the incidence is reported as 0.5 to 2.3% in peds. I personally think that's an overestimate. Most of those studies are being performed in really specialized populations like cardiac ICUs. It is more common in infants and adolescents, and remember that the development of the autoantibody takes about 5 days. So I think in my question, they specifically said that the patient had been on heparin for 5 days, so that was my clue. This is the 4T scoring, which can be helpful when you go to the PICU, because these patients are always complicated. There could be a million reasons they have thrombocytopenia, and you're trying to figure out, do I think they really might have HIT? So the 3 T's are thrombocytopenia, the timing of thrombocytopenia, thrombosis, and the last T is fairly awkward, but it's other causes for thrombocytopenia. So you're going to think more about HIT if the patient's platelet count is dropped by more than 50%, but it's not like our ITP levels. The platelet count is 20 to 40,000. If the timing's occurring 5 to 10 days after heparin exposure. That was the clue in my question. The only exception is a patient was in the hospital receiving heparin, is discharged, turns right around, and is back on heparin, and then they develop HIT. That can happen. If the patient has a brand new thrombosis, HIT is more likely. And if you look at the med list, if you look at everything that's going on with the patient, and you can't think of another reason they could have thrombocytopenia, it makes it more likely. So the trick with doing these consults is that you have to decide what you're going to do before you have your lab test back. Because if you really think that someone has HIT based on that 4T score, you need to stop the heparin right away. And that includes heparin flushes, because the thrombosis risk is very high in these patients. But because their thrombosis risk is high, you can't just leave them hanging. You need to start them on another anticoagulant. So this is when you're going to use your direct thrombin inhibitors that we'll talk about in a bit, argatroban or bivalirudin. How you test for HIT antibodies is you do an ELISA test that looks for these circulating antibodies. The problem with the ELISA test is a negative result is very helpful. You know the patient doesn't have HIT. But a positive result is not helpful because it has an incredibly high false positive rate. So you need the functional assay to know for sure, which is a serotonin release assay. However, that's a test that's usually going to take several days to come back. So what you need to do with these patients that you have a strong suspicion of is stop heparin, make sure to remind everybody that includes flushes, start them on argatroban or bivalirudin, send your testing, look for lower limb thromboses, and don't give platelets unless the patient's bleeding. And you're doing all that while you're waiting for your test to come back. So now we'll move from heparin to vitamin K antagonists. I think I've already hammered this one home enough, 2, 7, 9, 10, CNS. Warfarin is typically dosed once per day. The dosing can be quite variable, but in general, patients will be around 0.1 milligrams per kilogram per day in the end once you have them therapeutic. We already talked about why it must be given for another anticoagulant for at least 5 days, because you're trying to avoid that picture of the feet with all of the purpura on them. Sometimes you'll get a consult for, the surgeon calls you, they're taking someone to the OR, their INR is 1.3, we're canceling the surgery, you need to see them. Remember that the INR was only designed for patients on warfarin. Outside of that, it doesn't mean anything. Why it was designed is because the prothrombin reference range is different at various laboratories. And you want a patient with warfarin to be able to go to any laboratory and get a test result and know whether they're therapeutic. So the INR is the ratio of the patient's prothrombin time to the normal mean prothrombin time at the lab where they're having their INR checked. The target range is INR of 2 to 3 for the vast majority of patients. For cardiology patients with mechanical valves, you'll aim higher. We used to aim higher for patients with antiphospholipid syndrome, but that's fallen out of favor more recently, and typically we just do 2 to 3 unless they're a patient with recurrent thrombosis. The point of this slide is to remember that a lot of medications, a lot of food items can interact with warfarin. That's what makes it difficult to manage these patients. The list of medications is enormous. The ones I have included here are the ones that we most commonly use in pediatrics. Most of the rest of them are fortunately very rarely used in our patients. GI illnesses are a big one. If our patients call and tell us they have a stomach flu, we are definitely checking an INR because it could come back really high. Vitamin K foods are less of an issue as long as a patient is eating a fairly consistent diet. So where I see this as a problem is, like, I have some female college students that will eat pizza for a week and then eat salad for a week because they feel bad, and then their INR gets out of whack. Alcohol also affects INR, so that's another important thing to remember if your high school or college students are all of a sudden having some difficulties with their INR. And I listed some of the foods as well. You have to take these foods in like pretty significant quantities, like one mango smoothie, one grapefruit is not going to mess up your INR. It's important to know the various means to reverse vitamin K antagonists. It's more important to remember that you only want to reverse the vitamin K antagonist if you really have to. If you can get away with holding a dose or two and then decreasing their maintenance dose, that will be much better, because once you've reversed the antagonist, it's really hard to get those patients back to therapeutic, and you don't want to be bridging with low molecular weight heparin and creating a lot of confusion. So in general, if the INR is less than 5, you're just changing the warfarin dose. Even if the INR is between 5 and 9, you're still trying to adjust the warfarin dose alone if you can. If they're closer to 9 and you're worried about bleeding because of some other underlying issues they have or because they're an active toddler, then you might give low doses of oral vitamin K because you're trying to get the warfarin down but not completely reverse it. These items listed here on this slide are more for what do you do if you have a patient on warfarin who has a major bleed or needs to go to surgery right away. So those are the cases where you will use IV vitamin K, where you will use fresh frozen plasma, or where you would use a prothrombin complex concentrate. Okay. Next, we're going to talk about direct thrombin inhibitors. We will talk about dabigatran, which is the oral agent on this slide. The IV agents are argatroban and bivalirudin are not on this slide, but I wanted to just show visually how these agents are working on thrombin, or the other name for thrombin is factor 2. And these block both circulating and clot-bound thrombin. So this slide describes the different direct thrombin inhibitors. Argatroban and bivalirudin are very similar. They have short half-lives, they're continuous IV infusions. So pretty much you are using these agents in the ICU setting when you are worried a patient has heparin-induced thrombocytopenia. Outside of that setting, they're rarely used in pediatrics. Dabigatran is an oral direct thrombin inhibitor that's currently undergoing studies in pediatrics. I don't think you're going to be asked about dabigatran on a test, but you could definitely be asked about argatroban and bivalirudin. I don't remember the details, but I remember that was like one of the answer stems, as I needed to know that you would use those medications. Dabigatran is part of the family of direct oral anticoagulants, or what we call DOACs. And so there are, dabigatran is the only direct thrombin inhibitor in this family. The others, apixaban, edoxaban, rivaroxaban, those are the ones that are in clinical trials right now in peds, are all 10A inhibitors. These all have reversal agents at this point that have been FDA approved, although most of us don't have them in our pharmacies yet. And certainly we're very excited about these agents because we would love to be able to anticoagulate our patients without injections or laboratory monitoring. And that's what we're trying to learn with these studies, is whether that will be possible. I'm going to skip this slide because I don't think direct oral anticoagulants are going to be on your test. They're not ready for prime time yet. Duration of anticoagulation, this is kind of frustrating because these are the questions I get emailed all the time, but it's more nebulous, and I don't think it's going to be on your exam. They're going to ask you how these agents work. Right after I had to submit my slides, so I wasn't able to put them as a reference, but ASH guidelines have recently been published. There's a pediatric chapter. The first author is Paul Monagle. They're in the Blood Advances Journal in November 2018. I highly recommend you use that as a resource when deciding whether to treat, how long to treat, etc. For the purposes of this talk and the boards, I think you just need to remember that for a reversible risk factor, we treat for 3 months, usually shorter in neonates. For a chronic risk factor, like a patient with active inflammatory bowel disease or active nephrotic syndrome, we're going to treat longer. And for idiopathic VTE, we're going to treat for 6 to 12 months. So I think if you just know the reversible risk factor row and the idiopathic VTE row on this slide. That's all you need to know for the boards. Next, we'll talk about thrombolysis. There are a few different agents, but by far TPA is the most commonly used thrombolytic agent. This can be done as catheter-directed thrombolysis, and there's all sorts of new tools to help do this. There's also systemic thrombolysis, which can be low-dose or high-dose regimens. I'm not going to spend a lot of time on this or the monitoring in order to keep us on track on time, and also because these vary a bit by institution, and I don't think it's something you're going to be asked on a test. What I think you might need to know on a test is the indications and the contraindications. So possible indications for thrombolysis. The thrombolysis community kind of got a jolt this year with a big paper in New England Journal of Medicine from the ATTRACT study in adults, which was a randomized controlled trial of patients with lower extremity thrombosis comparing standard anticoagulation to thrombolysis. And to everybody's surprise, thrombolysis was not shown to have improved outcomes with regards to post-thrombotic syndrome. So that's kind of given people pause on when we should be doing this. The VTE guidelines that I just mentioned, published recently a few months ago, recommend considering thrombolysis in two scenarios. One is a patient with bilateral renal vein thrombosis with renal compromise, and the other one is patients with pulmonary embolus with cardiorespiratory compromise. I don't think the board exams are going to be up to date with the 2018 guidelines, but just to give you a sense of what they say. Other times when you might think about it are limb-threatening arterial thrombosis, severe intracardiac thrombosis. We already talked about PE. Extensive DVTs, patients with SVC syndrome, like this little guy, one of Dr. Young's patients, who has, you can see swelling of their face and neck, and increase in superficial vessels on their chest. You also think about this, we mentioned renal vein thrombosis, but large iliofemoral clots. The ATTRACT study was not powered to look at this specifically, but the sub-analysis did suggest that patients with large iliofemoral clots did benefit from thrombolysis. Most likely thing to be on the test, I think, are the contraindications to thrombolysis. These are major bleeding, significant potential for bleeding, recent surgery, semi-recent neurosurgery, a patient with seizures, patients with sepsis, bad renal function, uncontrolled hypertension. You don't want to take a really sick patient down to IR for thrombolysis. In terms of monitoring, again, I don't think the details are as important as knowing that you're going to be purposefully, with systemic thrombolysis, messing up the coagulation system. So you expect their platelet count to maybe drop, so you need to be ready to supplement that. You expect their fibrinogen to drop, so you need to be able to supplement that. And you want to make sure their hemoglobin is stable, because otherwise they might be having an internal bleed. And the last thing we'll talk about is post-thrombotic syndrome. So this patient, sorry, luckily I only have 4 slides left. I think my voice will last 4 more slides. This patient in panel A, you can see that their right arm is swollen. And you look at panel B, you can see that they have an increase in superficial vessels over their right shoulder and chest. And this would be a likely clinical scenario for a patient that maybe was in the ICU as an infant and had a central line placed, or maybe they're a ALL patient off therapy, and now they're coming in with these concerns for swollen extremity. The reason you get post-thrombotic syndrome is due to venous insufficiency. It will occur within 1 year of thrombosis in about 25% of patients with extremity DVT. It's due to valvular insufficiency and residual venous outflow obstruction. The good news is that even though it's common, by far most patients will have mild cases of PTS that are not impacting their health-related quality of life. This is a paper from one of my colleagues, Dr. Ratan Kumar, showing what the most common signs and symptoms of post-thrombotic syndrome are. So the patient will be complaining of pain or tingling, and on exam you'll see dilated vessels and swelling. We do have validated assessment tools for PTS, the modified Villalta scale and the Menko-Johnson instrument. And I already mentioned that the large majority of cases are mild. This photo shows an ulcer due to post-thrombotic syndrome. Very rare, fortunately, only in about 1% of patients. Who's at increased risk for post-thrombotic syndrome? Overweight teenagers, those patients presenting with extensive, particularly iliofemoral thrombosis or axillary subclavian thrombosis, patients who their ultrasound at the end of treatment still shows a lot of clot burden. I mentioned earlier, patients with really high factor VIII or D dimer levels at presentation have a higher risk of this, and those patients with thoracic outlet syndrome. The best way to prevent post-thrombotic syndrome is to prevent venous thrombosis. This could be a whole talk on itself and is not going to be on a board exam, but certainly you're probably all familiar with recent efforts in place to decrease hospital-acquired thrombosis through the use of scoring systems when patients are in the hospital, through the use of increasing mobility, compression devices, and pharmaceutical prophylaxis for those patients at really high risk. Quickly diagnosing VTE also helps. We talked about that thrombolysis may help in certain situations. Once PTS has occurred, our options are limited, unfortunately. We use compression stockings for these patients. Physical therapy can be helpful. Elevating the affected extremity at rest and maintaining a healthy weight is very important. Really appreciate your attention. Sorry if it was a bit of a whirlwind. Thank you. I wanted to make one more point. I'm sorry, I just came today, so I don't know if this has already been discussed, but for people who are here who are recertifying, you know you're allowed to pick heme-focused, onc-focused, or heme-onc-focused at the end. So I will say that as a hematologist, I picked heme-onc combined at the recommendation of other hematologists who had taken the test. Honestly, in retrospect, I would have picked onc-focused because I felt like the onc questions were much more straightforward. I either knew them or I had no idea and could move on, whereas the hematology questions I found to be much more nuanced. And I also found that a lot of hematology questions were patients with benign hematology disorders that were going on to stem cell transplant. And then I was like, oh no, I don't know anything about transplant. So just my advice for recertifying hematologists. Thanks again.
Thanks, Sarah.